We now have a period for question and answers. This is the first period for questions and answers. We'll have another one at the end. Please could I make an appeal as respectfully as possible? Could you focus on the core question that you want to ask this afternoon, rather than give way to the very easy temptation of, in a way, telling one story. We need to keep this conversation focused and on track, and so we would appreciate concise and clear questions for our panels and for our those of us present here to be able to respond. Thank you.
I have a question from the chat, from the Zoom. I folks, I'm moderating the Zoom meeting. This is for any of the first four speakers who wants to answer this. Saying basically that a just medical system can actually strengthen people's faith in government, and asking whether we can find a healthier democracy via a just and universal medical care, and how do you feel about that? Tough question, but does anyone have a thought on that?
Did everyone hear that question?
No.
Okay, great, thank you. So this question, can people hear me? Yeah. So this question is from the Zoom meeting, asking, saying that, repeating, I think, Mark's point that a just medical system strengthens people's faith in government. Can we find a healthier democracy via just and universal medical care? Tough one.
We hope that it is a path to a just medical system, but we also need to recognize how many avenues there are. I tried to touch on a number of ways in which we're really in competition individually, as corporations, etc., in a system that is made up of so many pieces that are in competition. Being a Medicare member is very handy, but I still get all sorts of advertisements for people who are sure they can give me a better deal. This kind of a market approach to healthcare hasn't worked anywhere I'm aware of.
One of the things about ensuring justice in the delivery of healthcare is not just about access, it's also about the control of costs. And one of the ways that costs are controlled in the UK system is that the government will set a national tariff for the price of a particular procedure. The incentive is then for the hospital to perform that procedure at less than the tariff cost, which enables them to pocket the difference. And so there is a kind of built-in incentive to keep the costs down, which is one of the main issues that we're struggling with in the United States.
Someone over here?
Thank you, Mark. It's related somewhat to what you just said. There are a lot of concerns about our Social Security funding, Medicare funding. There are questions about equity paid into that based on income. There's a cutoff now. If you make over $127,500, you don't have to pay more than somebody who makes $27,000 proportionately. Is levels of income or even age? Or does anyone who shows up at the door, whether they're 20 or 90, just come in and get a service? If anyone is a millionaire or at poverty level, just come in and get a service, because I don't think we're going to easily walk away from some kind of tie to a market-based system.
I don't want to set myself up as the kind of expert on all answers about the national health system. I've heard Americans often say to me, well, you know, in Britain you've got a socialized system for healthcare. We do not have a socialized system for healthcare. We have a system of healthcare that is free at the point of use. We pay for it. We pay for it through the national insurance tax, which is a graded tax, which is income related. But for those of us who are 65 and over, the beauty is, once you reach 65, you no longer pay.
My name is Dennison. I'm a doctor at Rhode Island Hospital, and I've been in private practice in Providence for a while. So I'm bringing up this important question. You know, housing subsidies are a really good idea, but what if you give someone a housing subsidy and there's no housing? What if you get insurance, but there are no providers? We've been through this. Memorial Hospital, Rhode Island shut down, and why did they shut down? The number one root cause was they could not survive with what's called payor mix. Payor mix is the combination of private insurance with Medicare, with Medicaid, and I work in a nursing home in East Providence, and I'll give you an idea of how payor mix works. If we get a private patient in, they have to pay about, I think, $400 a night if you're paying cash. Medicare pays about $389. I think private insurance about $390. Medicaid pays about $250. You get the idea. If you have too many Medicaid patients, you're out of business. And that's what happened to Memorial Hospital. They had too much Medicare, too much Medicaid, very little private pay, and very little insurance. They're out of business. So the people in Kentucky have no source of the hospital. The clinics shut down there, and this group of people have no access because they don't have transportation. So I'm very concerned, and I'm also a medical businessman, about this concern is, and anybody who's in business knows, the bishop's in business, he knows, you never single source anything in your supply chain, because if that supply dries up, you're out of business. And you don't want to have just one set of customers, because if they dry up, once more you're out of business. So I'm not sure who's qualified to really answer this, but I'm just going to present this as a thought question to all of you. If we go to a one-payer system and there's one purchaser, beware, because your providers may go bust. And what are you going to do about it? What's equitable?
Thank you, Dr. Dennison. I think some of those points I gave you addressed are strong.
If I may, I was just going to address part of that question.
So, hello everyone, my name is David Morales. I'm a state representative here in Providence, and I'll be speaking shortly in terms of state legislation regarding Medicare for all. So, the point that was just made is very important to understand in the sense of reimbursement rates. And one thing that we're going to do within our piece of state legislation is to increase specifically Medicaid reimbursement rates for different services that are available. And unfortunately, Rhode Island ranks in the bottom 50th percentile when it comes to reimbursement rates because we have not updated a lot of them since the mid-90s. So I want to be very clear, and I will be very clear when I discuss as well, that Medicare for all here at the state level would be about a 2 to 3 year phase-in. It would not happen overnight. We would have to essentially increase our reimbursement rates for Medicaid services. We have to increase state funding towards Medicaid, and a lot of that's going to include cutting out a lot of the quote-unquote corporate welfare that exists in our state budget that a lot of people aren't familiar with. We have a lot of tax credit programs that unfortunately benefit a lot of wealthy businesses, and as a result of that, we've often cut Medicaid or refused to update certain reimbursement models. So again, I want to provide the reassurance that Here locally at the state level, we could get it done even without having to wait on the federal government. It's all about how we maximize our finances, and I will go into further detail when allowed the opportunity. Thank you.
Right. That wraps up this section of question and answers. We can return to this later at the end of the program.